around the difficulties that we see with the airways themselves. And we classically have two types of functional breathing. Our ENT colleagues now like us to talk we once called paradoxical vocal cord movement, dimensional vocal cords, the adduction of the larynx with inspiration and expiration. We are now asked to think about that as being called inducible laryngeal obstruction. And the second thing that we have is breathing pattern disorders, of which the most common is hyperventilation, which can often compound and is very often in our acute asthmatics in particular, accounting for their low CO2 levels. I'm going to shamelessly plug a paper that we wrote a couple of years ago, myself and my colleagues in primary care here in Southampton, who's done much research on this subject. So if you want to know more about that, there's the go-to place to go and read about the differential diagnosis. It's as long as your arm, but it is very important to make sure that we diagnose. I believe Professor Bush talked about the importance of doing measurements and trying to get objective data to know that we really are dealing with asthma, the diagnostic condition that we're trying to deal with, rather than some other airway pathology that might be causing wheezing and coughing in our patients. I just want to briefly show you a flowchart that's shortly about to appear on our peer website. The peer website is a very useful resource you might want to look at, which contains many guidelines about many aspects of pediatric care. And we're currently working up content in the area of asthma for this. And this is a flowchart that we're hoping to use in the very near future across Wessex to try to aid our colleagues in making the accurate diagnosis. A big emphasis on the use of spirometry, and in particular that documentation and detection of reversible airways obstruction, which is really very much the hallmark of asthma diagnosis. There are other tests that can also be used to support the diagnosis, and those include the use of the measurement of FeNO, that's exhaled nitric oxide, a useful test in steroid-naive patients for diagnosis, also the measurement of peak flow variability. There are limitations with these tests. 1 in 5 FeNO measurements can be falsely positive, and 1 in 5 patients with asthma will have low normal levels of FeNO, yet still have asthma diagnosis. None of these tests are absolute, but they are important, and we should be thinking about how we can best use them in our practice to make sure we're making accurate diagnoses of asthma as a basis for which to go forward on in treating our patients effectively with the right medications and the right kind of approach to their condition. So I'm also not going to talk about anxiety and depression, but we do know there's a huge amount of literature now in the adult study and also increasingly now in children that highlights a very complex interaction between these kind of psychiatric conditions and the phenotype of asthma, which is typically unstable, severe, and can be difficult to treat when these things are present. But again, I'm not going to go into that in much detail, except just to make you aware that these are many other factors which are also impacting upon our patients and make the asthma difficult. But what are we left with when we take away all these things? What is difficult asthma? Well, we immediately hit on a difficulty because it's not really clear what we're talking about. And the British Thoracic Society, you mentioned, Chana, the BTS guidelines, and the most recent iteration of those in 2019, in their chapter on difficult asthma, made this very clear point that that really there is no definition of difficult asthma in children or adults that is universally agreed. And specifically, we don't have a level of treatment of asthma frequency to which the term difficult should be usefully applied. That we haven't quite nailed that as a community of pediatricians with respiratory interest and indeed adult respiratory physicians. And there is no real precise data that tells us really about the prevalence of these clinical problems. So this is immediately a problem that we face when we start to talk about this kind of patient who has difficult asthma. For some reason, my slides are not. So it's a bit of a black hole. It's a bit like dark matter. We don't really know what difficult asthma is. And I'm going to go on a bit of a tangent here and draw some parallels between this difficulty that we have in defining and understanding the problem and what happened to the Premier League football team, Sunderland, in the Championship Premier League in the year 2016 to 2017. And the picture you see in front of you is one of the football matches early on in the season. And you can see with his back to us in the white there, number 10, Harry Kane, who was the captain then of Tottenham Hotspur. And he's slipping a ball past and scoring a goal against Jordan Pickford, both players of whom went on to play in the England national team. And in that season, Sunderland did appallingly badly and ended up being relegated from the Premier League. And their manager at the time was David Moyes. And he was asked, well, how come? What was going on here? Why was your team languishing at the bottom of the Premier League at this time? And Moyes said something very interesting. And this is the quote that came out in the Guardian newspaper in September of 2016. And he suggested that there might be some intangible mental weakness behind his team's poor start, even an indefinable something that goes beyond rational explanation, a bad vibe, a hex. A hex is like a curse put upon somebody, or a shadow. Some interesting use of language to try to characterize the reasons why, despite all of the physical training, the pep talks with the manager, the coaching that was going on, the team just went from bad to worse. The fans were disappointed, and everyone ended up being relegated. And they've never come back from that, unfortunately. So there may well be some parallels here between the woes of Sunderland and an indefinable something that may also be similarly impacting upon asthma patients that makes their condition difficult to treat, despite all of the medications and the drugs that we have available to try to use to help them. And that's what I want to try to explore with you in this talk, and perhaps a little bit more laterally about how we might go about addressing this kind of problem in our patients. But before I develop that theme any further, it's always very important to start with the basics and get the basics right first when it comes to treating asthma. And I'm sure many of you, when looking at that picture in the right-hand corner, the young girl who's obviously feeling quite wheezy, there's something very obviously missing from that picture. And it's something that's very often missing in many such similar photographs which are taken to depict asthmatics in the social media. And of course, the reason her asthma is bad and she's not getting better is because she hasn't been using a spacer to take her inhaled medications. Her drugs aren't getting into her lungs, they're just impacting their upper airway. And so, the first thing to think about, of course, is to make sure you have the right delivery device for your patients. And that's particularly important in pediatrics. And you don't have to use expensive commercial spacer devices to overcome the high velocity of the meters dose inhalers impacting on the upper airway. Cheaper, self-made devices for spacers can be just as effective to be used when the more expensive devices are not so readily available to our patients. So a little plug there for the spacer at the start. Well, despite any unified lack of any definition, the British Thoracic Society, in their guidelines, made up one of their own. They clearly needed to have some sort of basis about which they could talk about difficult asthma. And they described it as being persistent symptoms and or frequent asthma attacks, despite taking high-dose inhaled corticosteroids, plus a long-acting beta agonist or a leukotriene receptor antagonist, or continuous or frequent use of oral steroids. So the theme very much that is here is that the medication isn't working. Difficult asthma is a situation that you come across where the medication that we would normally use to treat the condition are proving to be poorly effective in having efficacy that we might expect them to have in making our patients better. So what do you do about that, and how do you approach it? Well, I think people like myself over the years have been very much conditioned to thinking about a stepwise approach to treatment and escalating medications to higher doses, which may have greater efficacy and work better than what we're giving the patients at the time when they're less well. But that really may not be the answer. And simply giving more of the same in more and more doses could be thought of as being akin to flogging a dead horse. And as you know, flogging a dead horse isn't going to get you very much further forward. And perhaps that's not the best approach. And we need to think more laterally about other ways in which we can address this kind of a problem. And there is some scientific rationale to underpin that reason to take a different approach. And not least, it's studies such as this. This is over 16 years old, but I think the more recent data holds true, and it's much the same in studies in asthma in adults when we've looked at the dose response to inhaled corticosteroids. And here we've got fluticasone in pediatric studies, looking at improvements in lung function and improvements in symptoms in relation to escalating doses. And what you can see at a population level is very clearly that the dose response curves flatten off really quite low at a low level, and giving much more than 100 micrograms per day of fluticasone puts you into a realm of diminishing returns in terms of increased efficacy. The plateau to the dose response is occurring at really very low doses of these kind of medications. And this is very much true, I think, across all of the different types of inhaled corticosteroids that we have available. And so this is one of the main reasons why when we're trying to manage and treat difficult asthma, the many studies that have been done looking at exhaled nitric oxide, a marker of inflammation to try to guide management, have been negative and have not been shown to be of benefit in helping us to manage patients with asthma. I said at the start of my talk that measuring FeNO is very useful diagnostic tool in steroid-naive patients. But once we get beyond low-dose inhaled corticosteroids, and we're trying to manage patients who have difficult asthma and symptoms despite taking those treatments, using FeNO as a tool to try to aid your management does not help you. And that very much held up with the British Thoracic Society assessment of the data on this and their statement, albeit that some of my colleagues find this controversial and contest it. The consensus view at the moment on the evidence is that the routine use of FeNO testing to monitor asthma in adults and children is not recommended. There's a caveat there for specialist asthma clinics. Why they should be different to everybody else is frankly beyond me. And I think this statement should hold true for managing children with asthma. So what do we do? How do we approach this problem? Well, one of the often what's referred to as the elephant in the room, the not thought about problem. This problem is whether or not the children, the families, are doing what we're asking them to do. Could it be the case that the control of the asthma is difficult because the patient isn't taking the medication that you prescribed? And it's almost a non-brainer, you'd think, wouldn't you, that asthma might, if you're not taking the treatment for it, is not going to be well controlled. Well, I want to challenge that concept and just get you to think about that in a little bit more detail and think harder about what might be going on in situations when adherence is poor. And the thing that we've had in recent years to really help us understand more about what patients are doing in relation to what we're asking them to do is the advent of smart inhalers, smart devices which can electronically monitor the adherence to inhaled corticosteroid treatment. And you heard Professor Bush yesterday, and this is some data, a study published by his group from the Brompton Hospital. We looked at the use of a smart inhaler to monitor the adherence to inhaled corticosteroids in patients with severe difficult asthma attending the Brompton Clinic. And they studied 93 children. The median age there was 2 years, and they monitored them for about 3 months, 92 days. And when they looked at the data in this clinical trial, they found that about 42% of patients, 39 patients of the 93, were taking more than 80% of their treatment. They were doing pretty well and doing what they had been asked to do by the healthcare team. 25 patients, 27%, were doing less well. They were taking just 60 to 79% the amount of inhaled corticosteroids they'd been asked to take. And 29 patients, 31%, were doing really quite badly with their adherence and taking less than 60% of their treatment. And this was occurring in the context of a clinical trial where the patients were explicitly aware that they were being monitored in what they were doing. And this would suggest perhaps that in a setting where we're not carrying out research and monitoring patients more objectively to their knowledge, the situation is likely to be even worse than that. And the researchers went on to look at 4 different groups of patients. They broke them down into a group who had good adherence and who had good control of their symptoms during the 92 days. And they regarded those patients, 24% of them, as being on the right treatment. There were, unfortunately, however, another group of patients who had good adherence, but despite that had poor control, 18% who they thought needed more treatment. There were also patients who were poorly adherent. They weren't doing their treatment, less than 8% of the medication that was recommended, but they still had good control of their symptoms, 26%. And the researchers suggested that perhaps these people were being overtreated, or they were being told to be taking, and actually they needed less treatment. And then there were patients at the bottom here who had poor adherence and poor control, about 32%, who needed to actually do something about taking their treatment. And interestingly, they looked at a number of things such as FeNO, such as broncho, hyperreactivity, asthma, quality of life assessments at the start of the study. And none of these distinguished between these 4 groups of patients. And their conclusions was that, well, yes, smart monitoring is a great idea. This study is showing that you really need these devices, electronic monitoring of inhalers, if you want to assess poor adherence, which is essential to know about because you need to know if this is the cause of poorly controlled asthma. Now, I want to just look at this data in a slightly different way. And so there's that same data of the 4 groups of patients. What I've done here is I've put together the patients with good control and the patients with poor control. And you can see that you had 50% of patients with good control, either with good or poor adherence, and you had 50% of patients with poor control, either with good or poor adherence. So it's really 50-50 as to whether electronic monitoring at a population level for the clinic improves asthma control. So that's a very important takeaway message to recognize from this kind of study, that monitoring of the adherence per se doesn't help in the management of the asthma of the patients. So what's going on here? There's potentially a bit of a chicken and an egg situation about the relationship between the adherence and the control of the asthma, whether or not it's difficult to treat. So the conventional view of this is that the asthmatics are poorly controlled because they are poorly compliant. They're not taking their medication to treat their asthma until their asthma is not controlled. But it's equally plausible that the asthmatics are poorly compliant because their treatment is poor at controlling their symptoms. The drugs aren't giving them the benefits that they hope for. They're therefore disengaged with their treatment and they're not taking it. And there is actually a basis for thinking that the latter might well be true. Because again, when we go to the British Thoracic Society guidelines and the researchers looking at difficult asthma, who have looked at all of the interventional studies to try to improve adherence, they find that interventions to improve medication adherence do not clearly improve clinical outcomes. That's perhaps surprising, but it's true. And so the important take-home message that the ETS say is that interventions to improve adherence per se are not what you need to be doing, but they should maybe be a component of a management plan that is there to improve supportive care to the patients, not to replace supportive care by addressing the adherence in its own right, but to recognize that maybe the adherence is poor because the drugs aren't working and the patients need support in what they're doing to manage their asthma more effectively through supportive care. So what's this supportive care thing, and what are we talking about? And what is it that we can actually be doing practically in our clinical practice? Well, maybe that supportive care has got something to do with what David Moyes was talking about when he was addressing the problems with the Sunderland football team, who couldn't get their act together psychologically to play well as a team and to stay in the Premier League. That thing that went beyond rational explanation. And maybe in the context of asthma, we should be thinking about it as something that goes beyond the pharmaceutical interventions that we have to try to help patients. And that indefinable something, I would suggest to you, might well be the equivalent to what we often think about as the placebo effect. And the placebo effect, I think, is something which is extremely important in the management of asthma, and something that unfortunately has been hugely neglected in aspects of how we approach and think about and try and study this particular type of disease. What the placebo effect isn't is the benefits from taking a fake pill in a clinical. It's far more than that. The placebo effect is about the benefits patients accrue from the proactive engagement from healthcare professionals in managing their illness. It's about the advice, the support, the interest, care, and concern that we as healthcare professionals are providing to patients. But perhaps more importantly, it's about how the patients respond to it. It's their reciprocal engagement and belief in what we are trying to do to help them. And this, I would suggest to you, is perhaps the indefinable not responding to the drug and more drugs in situations when the asthma is difficult. And I would also like to just one really important finding from the Cochrane Library. And you'll know that the Cochrane reviews are held up as being the repository of the best evidence-based rationale for what we do to treat our patients. At the top of the evidence is the meta-analysis of randomized controlled trial data. What randomized controlled trials tell us is that the size of the treatment effect and the size of the placebo effect in trials comparing an active medication against placebo are both dependent upon the levels of adherence to either the drug or the placebo. So the patients who are taking the placebo most actively and are most engaged in the clinical trial do far better than the ones who don't take the placebo, in exactly the same way as the patients who do better in the clinical trials are the ones who are taking the medication more than the ones who are taking less. So adherence is massively confounded by the placebo effect. And it may well be that the placebo effect is just as important or even more important than the adherence. So that's all very interesting, and it's a little bit theoretical perhaps in terms of what we're saying. But what does that mean in real world medicine and in the patients that we see in treatment? And what data is there that's out there to show how powerful the placebo effect is in benefiting patients with asthma? Well, I gather that Professor Bush mentioned leukotriene receptor antagonists, and I don't think he was that complimentary about their clinical efficacy. And I'm afraid you're going to hear some from myself. This is a slide taken from a study in 2009. It's a very, very good study. It's got over 116 patients in each of those 5 treatment arms. And the one on the far right there are patients who are receiving usual care in the asthma service. And these 4 groups of patients, these 2 patients groups are both receiving placebo medication. The patients here where it says NEUT, N-E-U-T, are being given no particular information or advice about what the drugs they're receiving might be doing. The patients with the information ENH are being given enhanced information and being told they're being given a fantastic new drug that's highly effective. And similarly, the 2 groups of patients on the left-hand side are those who both received montelukast, and some of them have been being told, take the drug, see what happens, no particular information about the medication. Far left are being told, take this, it's fantastic, it's a great drug, it's going to make your asthma better, you're going to feel really good. And when they looked at asthma quality scoring, what they found was that in the clinical trial, patients who received placebo and were being told the drug is great received exactly the same, very similar clinical benefit in terms of patient-reported outcomes to those who received the active medication, what was said about it. Now, what about acute asthma? This is a publication that came out last year in the American Journal of Respiratory and Critical Care Medicine. It's looking at asthma studies in adults, but it's looking at important clinical outcomes across the 5 studies where they were looking at benefits from interventions compared to a placebo group for whom there were no interventions. You can see here when we looked at things like asthma hospitalizations, where it was in 3 of those 5 studies in the center here, they were seeing benefits in the order of 2/3 reduction in the numbers of patients requiring to go to hospital and be hospitalized for acute asthma, receiving placebo, but being in a clinical trial where they were trying to impact upon these kind of outcomes. And similar benefits here for emergency department visits and asthma exacerbation, between 20% and 56% reduction in these kind of outcomes. And looking at asthma quality of life scores, again, consistent improvements in all those groups receiving placebo, and also consistent but moderate improvements in lung function as a result of the placebo intervention in all of the clinical trials. What about chronic asthma symptoms on a day-to-day basis? Well, this is a typical slide showing you the sort of thing happen in a randomized controlled trial. This includes adolescents and who are steroid naive and receiving inhaled corticosteroids for the baseline treatment being bronchodilator use only when necessary. And you can see, as typically occurs within the first of receiving steroids, you have a significant improvement FEV1 from the baseline in the active treatment, shown there top line with the squares, plateauing at around 20% improvement in baseline. But look at the placebo group. The placebo group is showing a very similar trend, albeit that the benefits are not as great. But perhaps the important message here is not just that the steroids are effective and work, but that 60% of the benefit of that treatment through placebo. And so the proportion of the benefits of the drug is perhaps much smaller than you might expect if you didn't have a placebo group to take account of the placebo effect of the support benefits of being in the clinical trial, which are also very important. Take that concept of the placebo effect as we've just and think about it in a clinical situation. I've shown here the same kind of data as we saw in our slide a 50 to 60% placebo effect, and above that, the pharmacological effect of the benefits of taking an inhaled medication. And on the graph there on the axis, we've got, on the y-axis, we've got good control, poor control, with the representing no symptoms. So what happens if over time, the patient goes on to develop symptoms? They become asthmatic. Well, our go-to thinking around that sort of scenario is that the drugs aren't working. We've had a loss of the pharmacological effect of the drugs in alleviating the asthma and controlling the symptoms. And therefore, our response to that should be to step up the treatment and to give more or alternative asthma medications to try to improve the patient. But it's just as likely that the reason why the symptoms are occurring may be because of the loss of the placebo effect. And perhaps the approach should be is not one where we try to give more drugs, try to recapture the placebo effect through patient-supported care that benefits that we got at the start when the drug was first introduced. So I'm coming to the end of my talk now. There's a couple of things I just wanted to talk about before I finish. And this is a new term that I've come across recently, methodological fetishism, a bit of a mouthful. And this is used actually in the context of our COVID-19 pandemic that we've all been dealing with in recent months. And it's something that's been used somewhat disparagingly by some doctors who have accused other doctors who have been very insistent upon the need for good methodology, well-conducted randomized controlled trial data to base decisions about managing COVID-19, both at a public level and in a clinical situation when we're giving drugs. And I am very happy to say that I am a fetishist. I am somebody who is very much in the camp of thinking that it is very dangerous to go about treating good quality trial data to support decision-making that we're having to make to deal with difficult clinical problems. And unfortunately, when it comes to asthma, we hit a big problem here. Because asthma studies that are not designed to take into account the placebo effect will undoubtedly massively overestimate the effects of pharmacotherapy. That slide I showed you of fluticasone showing you that 60% of the benefit is placebo. And when you look at interventional studies for asthma, particularly all of those which look at what to do in difficult asthma, what do you do beyond the first-line preventer treatment? Do you add in a long-acting beta agonist? Do you add in a Cochrane receptor antagonist? Do you double the dose of inhaled corticosteroids? I think without exception, I'd like to see the study that has done this. I don't think it's been done. There is no comparator placebo group. So we don't really know what the benefits are from these medications in this scenario and what extent those benefits that we do see that are reported might well be simply the effect of the placebo effects of being in the trial where these drugs are being used. And similarly, we have similar problems in real-world studies. And real-world studies, have become very popular more recently. Their advantage are that they look at real-world situations. They don't have a rarefied, highly selected group of patients who are rather homogeneous, very similarly with similar backgrounds, taking out all the comorbidities, the smoking, the other issues, in particular in adult studies, the cardiovascular disease in adults, a high selected group that don't represent the real world in RCTs are often looked at in real world studies. But what you tend to find in real world studies is that all drugs are equal. Everything seems to work. And you don't see differences, for example, between the leukotriene receptor antagonists and the use of long-acting beta agonists, the opposite to what you see in randomized controlled trials. The reason being is that these studies, again, do not have the placebo arm for comparison. We don't know the extent to which any benefits in real-world studies might simply be an effect of placebo, because placebo is not accounted for. And as I think I've shown you, those effects in asthma are huge. So what does it leave us? Well, I thought I'd leave you with a flowchart that published last year in the BMJ, thinking about treating difficult asthma in adolescents. I think it's largely true, but I think there are some qualifications to make as we go through it. And we'll start at the top. And I think that the first box holds true. Clearly, correct inhaler technique is something that we have to get right, and we need to make sure our patients are inhaling their drugs correctly, they're using appropriate spacer devices, and that side of things is being addressed. Adherence, well, yes, we have to think about adherence. It's important to address it, but I think there's a caveat to that. We need to be recognizing that adherence may not just be the problem. The problem may be the drugs aren't working, and that's why the patients are adherent. So a little bit of lateral thinking around those issues. Touched on very briefly at the start the importance of thinking about those comorbidities. And the most common, I think, particularly in difficult asthma, are the dysfunctional breathing type problems, the hyperventilation, the laryngeal type problems that patients get themselves into difficulties with. And physiotherapists, rebreathing techniques, retraining exercises, lots of resources on the internet you can go to that can be very useful in trying to address that side of the problem, which can be very highly effective. We touched on very briefly the emotional anxiety and other stresses, which are very important, not just, I think, in the cause of asthma, but in defining the phenotype and the challenges, the complex ways in which those kind of morbidities interact with asthma in all sorts of different ways is a bit of a minefield, but is a very important part of what's going on. So if we're still having problems despite all that, this slide said that maybe we should be then thinking about increasing the asthma medication to control symptoms if none of this is impacting upon the patient. I have to say now that increasingly that's not what I do. And what I tend to do instead, before I increase treatment, is I change the treatment. Rather than escalate the dose of inhaled corticosteroid, I will give the patient a different type of inhaler. And what I'll tell them is that it's a really good inhaler. I'll try to do things to maximize the placebo benefits of what I'm giving the patient. I will get a nurse to be engaged with the family, and I will often follow the families up myself with frequent telephone calls and supportive care to hear about the feedback about how well the new improved inhaler they're taking, the Ferrari of inhalers, I sometimes use that phrase, or the Rolls Royce for my posher patients, to try to give them the idea that this is something that's really important and beneficial and great for them. And the feedback is quite extraordinary. And if that's not working, well, then I'd give them another inhaler and tell them it's really, really good, and try to doubly reinforce the placebo effect. Although in practice, I have to say, I work with just one or two different types of inhaled medication and rarely have to use a whole range of different devices and different drugs to achieve these benefits. So I'm coming to the end of my talk now. I'd just like to leave you with some key learning points. The first one is to be suspicious, be highly suspicious about the results of any asthma study that does not include a placebo intervention arm. Drug v drug comparisons may show benefits of one drug or another drug, but the extent to which that's largely due to placebo effects, if they're not taken account of, may well be huge. And you're usually just looking at a massively overestimated pharmaco effect as opposed to what's occurring through placebo. Think about how you can best provide supportive care for children with asthma in your service, and embrace the power of placebo to do that. And maybe think about how you can do that by changing treatment rather than simply giving more and more medication in a way that's akin to flogging a dead horse. Thank you very much.
Thank you very much, Connett. I'm sure that this is a very difficult task to cover within this about 40 to minutes to 1 hour durations, but I'm sure that you have covered the given comprehensive outline about the approach to child with difficult asthma. There are many questions regarding, especially importantly, you have stressed about this placebo effect and the supportive care. I'm sure that most of the world, our part of the country, our part of the world also, we must not pay much attention about this placebo effect and all this. And we have some questions. So, first question I would like to ask, sent by one of our attendees, is regarding the placebo effect. Is that played by the treating physician? Will the trust on the physician enhance the placebo effect?
Absolutely, 100%. And I think this is the point I'm really trying to make. It's important as what we say to our patients as much as the drugs that we prescribe to them. And it's not so much what we as the attending physician are saying, it's what the response of our patients is to what we are saying to them. So we've got to think about what they're taking away from the consultation and how that's impacting upon their thinking in terms of how they're responding to what we're saying to them. So yes, 100%.
Yeah, and considering this difficult asthma, so inhaler technique is one of the common thing we pay much attention, and there are a lot of controversy and things about the inhaler techniques. So we have one question. So what is the most effective way of taking inhaled corticosteroids? Is it with the 10 breath technique or breath holding technique?
Okay, so I'm not sure how important it is, but I think what you're wanting to do is to avoid the high velocity deposition of the aerosol in the upper airway, and you're wanting to avoid to take a high flow rate, which causes turbulence, and again also contributes to deposition in the upper airway as opposed to intervals. So what I think is important in terms of what your technique is that you are using a slow breathing technique. And the idea being that you're actually allowing laminar flow of aerosol into the lungs periphery more effectively than taking a fast, rapid inspiratory effort of an aerosolized medication, which is going to impact in the upper airways. I think those are the principles that are at stake here. The number of breaths, I think we tend to take more than we need to, often recommended. And if you think about the tidal volume with deep breathing, think about the volume of the chamber you're using. I think most large volume spaces in school-age children are empty within 2 to 3 reasonable laminar flow breaths, which are not fast and rapid. Those are the kind of principles that you're going to have be thinking about when you're using these treatments.
Yeah. And there's much interest about this, the exhaled nitric oxide in children with difficult asthma. But the problem is our part of the world is not available really.
Well,
we have, we have one question that reliable is the blood eosinophil count in difficult asthma, since we do not have wide level facilities to check this.
Well, the short answer is I don't use it. I have colleagues who do. I don't, and I don't problem not using it in the management of my patients. And the reason why, as I trying to get across in this talk, is that the reasons for the continuing asthma symptoms, despite taking low dose inhaled corticosteroids, is not necessarily related to ongoing steroid responsive inflammation. That's the point. And so the FeNO may be high, it may be low, but it's probably irrelevant to the ongoing cause for the asthma being uncontrolled. And so I don't think it's a part to play. There are colleagues who will disagree with me, and we have adult colleagues who have worked hard looking at very intensive clinical trials with monthly and treatment based on expectorated eosinophil counts and titrating the asthma drugs according to the amount of eosinophilia they find in the airways. But I'm also aware of studies which look at eosinophilia, and there's no relationship between the severity and the number of eosinophils in the airways in adult patients, for example. So I think it's not all about the inflammation. I wouldn't want you going away thinking that inflammation is not important and that it's not the crux of what's happening in chronic asthma in the majority of patients. But if it's not controlled with low-dose therapy, then the reasons for the asthma being difficult is probably something to do with ongoing inflammation for which you need more drugs and which FeNO will tell you anything useful about. I have patients, I have colleagues who have patients, let me rephrase that, who are on oral steroids with very high FeNO levels. Very effective, massive anti-inflammatory therapies, but high levels of FeNO. I don't think FeNO is important.
Yeah, even though you didn't discuss about this dysfunctional breathing, there are a lot of queries about dysfunctional breathing. And then one question is that are there any specific behavioral techniques that we could employ in overbreathing or dysfunctional breathing?
Well, I'm not a psychologist, and I don't pretend to do psychology and treat my patients. But what I do have is the support of physiotherapy colleagues, and I think these people have a very important part to play. We don't do anything particularly high tech with these patients, but we explain the nature of the child's symptoms. We use the Nijmegen score. I think I've mispronounced that. Nijmegen score. It's a Dutch study. It's spelled MEGN, I think it is. And this is a very useful tool for picking out those patients who have poorly controlled symptoms for which there's likely to be a hyperventilation component. And those patients who've got high scores in this rating scale, we do that in all our difficult asthma referrals. And we share that information with our patients. We say, hey, good news, you haven't got bad asthma. What you've got is hyperventilation. And we can treat that with a physiotherapist. And we refer them to the physiotherapist, and they simply teach breathing control exercises, which is largely based upon the idea of diaphragmatic breathing. We know patients tend to breathe at high resting lung volumes, a lot of thoracic intercostal breathing, a lot of tension in the thorax, and a lot of compounding that, which can make the problem difficult. It causes chest pain in particular, which is not really an asthma symptom, but is very common in difficult asthmatics. And what we teach is relaxed, controlled breathing with the diaphragm, often supine initially and gradually with elevation into standing and walking around. And that can be highly effective for hyperventilation. Something that's been used in primary care settings for adults for all patients. It has been highly effective across the spectrum of primary care asthma in adults. And I suspect the problem's just as great in our pediatric practice.
So we have many questions. If you're okay, we can take a few more questions. Yeah. So an allergic rhinitis, that is also one problem associated with children with some difficult asthma. So are there any identified, so how common is post-control allergic rhinitis is making asthma control difficult?
I don't know the answer to that, if I'm honest with you. I think there can be confusion about what is asthma and what isn't asthma. And what can sometimes happen, I think, is you attribute a diagnosis of asthma to a patient, and then they automatically attribute any kind of symptoms that they then go on to have as being. And the rhinitis is a different type of a condition, in my opinion. It's an allergic illness. I think the role of allergy in asthma is probably stated, but clearly it's important in nasal symptoms of nasal rhinitis type allergy problems. I think there are colleagues who will say that it's one airway, and we should be treating both the upper airway, and that may well improve the lower airway. And that, I think, is not good. But I think it's quite common for people to feel as if their asthma is worse because their nose is blocked. Perhaps they're mouth breathing more, they're cooling the airways more. They could be dehydrating their airways more. That may impact upon bronchial hyperreactivity. and clearing the nose and enabling better nasal breathing may be beneficial. But I do think they are different diseases. One doesn't cause the other directly.
Yeah. Again, we have another question. Are there any identifiable predictors of difficult asthma?
No. There you go. No, there's not. I mean, and I think that's been shown. There's not, and it's interesting how I'm reflecting with my colleague, your colleague Hasita here, about phenotypes have changed over the years, and certainly when I started, the difficult bad asthmatics in my adolescent population were all children who had asthma from very early childhood, often from the first year of life. And were difficult to control throughout their life, continued into adolescence and often into adult life. Whereas now we see difficult asthma appearing for the first time in teenagers, where we didn't see it before. And so I think the phenotype is expanded and become more diverse and is not typical. And I suspect because asthma is a final common pathway from these many different comorbidities that we've been talking about, including the dysphoria breathing masquerading as difficult asthma and the psychosocial stresses which are increasing amongst our young people in modern day life, which also impact upon the asthma phenotype. So I think it's quite complicated and it's highly variable.
Yeah, so this air allergens and allergens, that is also some concern with children with difficult asthma. So do you think the allergy testing in children with difficult asthma?
Well, my colleague, Professor Roberts, who works with me in Southampton, will tell you it's very important. And he's done work showing a link between near fatal asthma, severe asthma attacks, and the co-association with food allergies playing an important part in that. I have to say, within my own practice, I rarely see it. And whilst there may well be a common pathway whereby emotional stresses and anxiety heightened bronchoreactivity, the tendency to anaphylaxis and life-threatening allergic reactions, it's more a case of them being associated to a similar underlying cause rather than being directly related to each other. That would be my opinion, but there will be others who would tell you that it's not like that and that they are associated.
Yeah. Then what do you recommend regarding this allergy testing?
Allergy testing, I rarely do it in my own clinical practice. The only studies I'm aware of which are relevant to this has been some colleagues in Manchester who have looked at house dust mite sensitization and recognized that may be a risk factor amongst their aspirations for future asthma attacks, and that maybe there's some role for modifying the environment and impacting upon that. Again, I am not in that camp who thinks that the allergy is the main problem here, and that I think that too much focus on that without addressing the things I've been talking about is perhaps not the best approach.
Yeah. And regarding this medical management, I have one question regarding these long-acting antibiotic agents.
Yes,
there's place in children.
Well, I think these are interesting drugs. This is the alternative to a beta agonist acting on the cholinergic pathways, the neural mechanisms which may be causing bronchoconstriction. And I think that throws up in thinking around the brain-body interactions, which might be important in determining bronchoconstriction, which has been shown repeatedly in clinical trials, psychological experiments to occur. And may well be important. And I think we do have very good data, certainly for acute asthma, that anticholinergics have additive benefits to agonists in achieving bronchodilation. So they certainly do have a place, I think, for acute therapy. Their place, I think, in chronic disease management, in chronic asthma, I don't use them. I think I have one patient who uses them. There's been some thinking that maybe, when we're having patients who are getting bad asthma around times of stress, around exam time, perhaps returning to school, pressures from other causes. Maybe the anticholinergic pathway may be more important by taking these drugs, blocking the nerves to the airways. But I think in practice, I haven't found those drugs particularly effective. You should remember that anticholinergics have a slow onset of action. Their peak of action is half an hour to an hour, and they're not as effective as short-acting beta-2 agonists and some LABAs, which are being effective within 2 to 3 minutes.
I think we are running out of time. We have many questions, and so it's a time to conclude this session. So I would like to thank Professor Gary Connett to spending your very precious time. I knew that this is your hot week. You are on call for the this week, but kindly accepted our invitation. So on behalf of the President and the Council of the Childhood Respiratory Disease Study Circle of Sri Lanka, I would like to thank you. It's a really great pleasure. So 2 years ago, we had your physical presence, and this year is virtually. So thank you very much, Professor Gary, your kind acceptance of our invitations and doing excellent presentations and this Q&A session. So thanks, Dr. Hasta Kajivir also. He did all the coordinations and arranged this. And finally, the GSK and Mr. Tony Dikau for facilitating this and giving technical support. So tomorrow there will be another webinar regarding pediatric bronchiectasis by Prof. Anby Chang. So it will be also an interesting one. So I think, Hasta is here. So nice to meet you. Yeah. So thank you very much. And I'd like to thank all the attendees from Sri Lanka and India as well. So they have taken this opportunity to upgrade their knowledge of difficult asthma. So thank you all. And so we're going to conclude this session. Good night.
Thank you. Goodbye.